Good afternoon, everyone, and happy holidays. I hope everyone is safe and healthy. And just a note before we get started here, I have a couple of announcements, but want to express appreciation to all the clinicians in the group for everything that they're doing to manage the burden of this pandemic in our community. And we know it's taken a lot of gas out of your tanks, but we appreciate everything that you're doing and wish you and your families well. To share some good news, I see that she's online, but I wanted to acknowledge Dr. Laura Scherer for her recently awarded R01 from the NCI to understand affective processing of scientific evidence to promote informed choice for breast cancer screening. I would kind of allow her to say a few minutes, but I know she gets excited about this and wouldn't want to cut too far into Carmen's time. So we're really excited about this work. Congratulations, Laura, and we're so happy to have you a part of the Cancer Center.
Thanks, Jamie.
There are some other good news, pieces of good news, some really great scores that I've heard about and we'll be announcing hopefully in the near future. And please, if you do have information about someone that you know who's received a great score or a notice of award, we tend to hear it, but sometimes it's a little bit later on the process. Please feel free to send Raj or Stacy or I an email, and we'll make sure that it gets out there for public consumption. Wanted to also let folks know we have a couple of other upcoming talks on the horizon that I want to let you know about. First and foremost, Dr. Katie Smits from Penn State Hershey is going to be here. We have, thanks to Dr. Heather Leach at CSU, we've been able to kind of leverage off an invitation that the CSU offered to Katie to come and talk about her research and exercise science and exercise oncology. And she'll be talking about her exercise trials in advanced cancer patients. That presentation is on the 11th at 3 o'clock in the afternoon. They will use Teams. If you haven't had a chance to register for that, there is, Ellen has posted to the CPC listserv, and Ellen, we could perhaps post that again because we need to get you'll need to get the link from the CSU team in order to join for that presentation. The other presentation that's on the horizon is our own CPC seminar for January, which is Dr. Robert Wynn. Dr. Wynn is an outstanding scholar, clinician, scientist who is the director of the VCU Massey Cancer Center. Notably, he is the first African-American to lead an NCI designated cancer center. He is an outstanding individual with really broad interests in cancer care and health disparities. And notably, he spent some time here at the University of Colorado. So we're in some ways digitally welcoming him back to the university for to get his insights into some health disparities in cancer care, as well as a lot of other experience that he brings to the table. And we'll have some more information coming out about that visit in January, but it'll be on the 13th. I want to transition now to introduce Dr. Carmen Lewis, who is an associate professor in general internal medicine. She obtained her MD from UT Southwestern, as well as an MPH in epidemiology from the University of North Carolina, Chapel Hill, who were soundly defeated in basketball yesterday by my Iowa Hawkeyes. Sorry to bring that up, Carmen. She started her career at VCU and then transitioned to UNC, where she served as director of the decision-making research group at the Sheps Center, a highly respected health services research center at UNC. We were fortunate that she joined Colorado in 2013, where she continues to conduct research on health services, importantly for today's talk, and shared decision-making and patient-centered care. She has held NCI funding to explore colorectal cancer screening, and particularly asking some of the really tough questions about when to end screening screening towards later in life, and how to have those discussions with folks to help make that informed choice or shared choice about continuing. And without further ado, Carmen, will turn it over to you to talk about appropriate colorectal cancer screening in the elderly. And thanks for your time today.
Yeah, thank you, Jamie, and hello, everybody. And feel free to interrupt anytime with any questions. Nice to see some friendly faces out there. And I am indeed going to talk about appropriate colorectal cancer screening in the elderly today. So here's kind of the journey that I have been on, and I'm going to take you kind of on to walk you through the journey that I've had. So first, I'm going to discuss kind of the evolution of colorectal cancer screening in the elderly, because I think sometimes now stopping things has become kind of commonplace. And back when I started this work, it actually wasn't. So I want to give you a little bit of context for this work, then review the literature for colorectal cancer screening in the elderly, and then I'm going to present results of a randomized trial that we did with a decision aid to promote appropriate colorectal cancer screening in the elderly. No conflicts of interest to declare, and recognizing that there's not all clinicians in the audience, but I want to present 3 cases so y'all can see the spectrum of decision making and the spectrum of functional status and comorbidities that can occur as we're making these decisions, because that becomes one of the key factors to consider. So I'm going to present 3 cases, and I want you to be thinking about what would you recommend to the patient? Would you recommend for or against, or would you do something else? So our first case is Mrs. Watson. She's an 80-year-old woman. She's had hypertension for 10 years, and it's been well controlled with hydrochlorothiazide. She's otherwise healthy. She has a good functional status. She walks several miles every other day, is very active outside of her home, and she travels frequently. So that's case number 1. Oops, supposed to be case number 2. Sorry about that. All right, case number 2 is Mrs. Perry, and she's an 80-year-old woman with moderate COPD, which is obstructive lung disease. She's been well controlled with medicine for hypertension, but she has severe osteoarthritis in both knees, and this limits her ability to walk outside her house. She experiences shortness of breath after walking up 1 flight of stairs. And case number 3 is Mrs. Brandon, who's an 80-year-old woman with severe heart failure. And this is due to coronary artery disease. She has shortness of breath with exertion, even though she's on optimal medical management. She was revascularized or had a CABG more than 10 years ago, but she's not a candidate for a repeat CABG at this point. She's able to take care of herself at home, perform her activities of daily living, but she must perform them slowly because of shortness of breath. So those are 3 cases, and I want you to keep those in the back of your mind. They'll come up later. And as you can see, there's 3 different kind of buckets. There's a case number 1, the woman is very healthy and able to do most things. They're all 80 years old. Case number 2, the patient has a few more comorbidities, but is still functioning fairly well. In case number 3, as you can see, this person is not functioning really well and has kind of progressed comorbidities that is limiting her functional ability. So keep those in the back of your mind. And so now I'm going to first talk about the evolution of colorectal cancer screening in the elderly. And some of this applies to other preventive services like mammogram or prostate cancer screening as well. So it wasn't that long ago, or at least not to me, that when you talked about screening, there was only one message, and that was get everybody screened all the time, and whatever you do, don't ever stop, no matter how old they are. This was also focused on because as people age, they have increased risk for cancer, for developing cancer. And so the thought was we just keep screening until people die. Then things got a little more complicated. So this was the first really time that people started thinking about recommending against something. This was in 2008 when the U.S. Preventive Services Task Force recommended against routine screening. And this was their statement at this time, although it's changed a little more to be more clear that it should be individualized decision making. But they actually recommended against routine screening. And then if people are healthy and there may be some other considerations that you might want to continue. Then they out and out recommended against screening for those 85 and older. The way that they present this has changed a little bit, but the idea has remained the same since 2008. And so why is that? Why did they decide to come out against routine screening for people with older age? And this is hopefully can be seen pretty clearly. So what you see on the y-axis, on the x-axis is time after screening, and you can see years going out to 16 years. And on the perpendicular axis is the number of colon cancer screening deaths per 1,000 people screened. So the first thing to notice is that the curves, the control group is in the green and the screening group is in the red, and the curves don't start to even look like to separate a little bit until 6 years. And they're clearly not separated until 10 years. And if you hear people talk about why we wait 10 years, people should have life expectancies of 10 years. This is kind of the why of that. And this is a meta-analysis done to demonstrate that. So you can see that there is a lag time before you benefit from colorectal cancer screening. And this is because the cancers are slow growing. So if you die before 6 to 10 years, you're not going to benefit from having undergone screening. At the same time, there are becoming more and more data on concerns about harms of colonoscopy, especially as people age. So we've got information about the risk. So it was 0.6 per 1,000 procedures. And this is one study from Warren, but there's been others and some since then. And also it showed that as you age, you have an increased risk for serious GI events compared to people who are younger. So comparing the 66 to 69 group compared to the 80 to 84 group, the older group has a 75% increase in serious events. Also, they noted in this study, and it was one of the first ones done about harms in colonoscopy, that if you previously had a stroke, heart failure, COPD, or AFib, you are more likely to have adverse events by undergoing colonoscopy. So this basically means that we had a recognition at this time of overuse in the elderly. So not everyone's going to live long enough to benefit after they've undergone screening. There are certainly risks of colonoscopy, which increase with age and comorbidity. And basically for individuals, the risk depends on their age and their health state. And this, we take all this for granted, but this was kind of new happening at this time to be thinking about harms actually. So then I'm going to review quickly some of the literature that supported this decision making. And one of the people who started this work is Louise Walter, who is at UCSF. And she in 2009 published a study in veterans looking at comorbidity, and what she showed, even veterans with severe comorbidity, 40% had undergone colorectal cancer screening. The other part of this is she found that there was no differences between those who were in a better health state versus those in a worse health state. The screening rates were about the same. Royce in 2014 looked at it in a different way. Those people that had a risk of dying within the next 5 years, 40% had undergone screening despite this high risk of dying. And then Goodwin looked at repeating colonoscopies more frequently than recommended. So in these 80-year-olds that they looked at, 33% had underwent repeat colonoscopies within 7 years. So where's the demand coming from for overuse? So, it could be that patients are requiring and physicians are saying, okay, we'll do it. It could be that providers are in favor of screening everyone until the very end. It could be that providers are deferring because of uncertainty around who could benefit. So the safest thing to do is to go ahead and recommend that. So we kind of, in our work, kind of did a deep dive into these reasons. The first side of the equation is it potentially patient demand? And this is one of the first pieces of work I did in this area, looking at patients' attitudes about continuing or stopping cancer screening. And this was kind of all cancers at this time. And it was a select population. People were in a continuing care community near Chapel Hill. We did in-depth interviews with them to kind of try to understand this. And what the bottom line was that 62% didn't think life expectancy was important in their screening decisions at all. And almost 50% preferred not to discuss life expectancy at all. And only 13% thought they would not live long enough to benefit from screening. So we figured there was a lot of education that needed to be done around this area at that point, even though these people were very intelligent. If anybody was going to know this information at the time, it would have been these types of people here. You can see that it was just not on their radar at all. Similarly, we did a more representative sample. We did an analysis from the National Retirement Survey here, demonstrating that a small portion of people that responded to this survey actually had thought about stopping any type of cancer screening. You can see prostate, colon, and breast there. So the proportion was less than 20% in all areas, and only in breast was it a little bit higher than 10%. So this was not part of people's thought processes for older folks. So then we looked at the provider side of the equation and did a national representative survey of primary care physicians. And they actually responded to the 3 clinical vignettes I gave y'all at the beginning of the talk. They provided us life expectancy estimates and their screening recommendations in response to this survey. And what we found was we had a hypothesis that really the decision-making wasn't binary. It wasn't get screened or not get screened. That after we'd done some qualitative work with physicians, they thought of it actually as in 3 buckets, that people that were in good health, it was likely that they would recommend screening. People in poor health, they would recommend against screening. And people in fair health, they wanted input from the patients themselves. And this played out in our survey fairly well. You can see that under the good health, the most common response was recommend in favor of screening. And for poor health, the most common response was recommend against screening. And this was kind of important at the time because it wasn't clear that physicians were actually recommending against screening at all. Of course, these were vignettes, but at least that they were saying that they would do so. And then there's this intermediate group, which we're calling the fair health. And you can see that the most common response was recommendation depends on the patient input. So more of a shared decision-making approach. So this is kind of the first inkling that, perhaps it's not all a preference sensitive decision. Perhaps physicians are trying to nudge people in good health to get screened, to nudge people in poor health away from screening, and to really do more of a preference sensitive decision-making process with those in the intermediate group or the fair health group. But at the same time, even though there was this huge concern and it was becoming more and more apparent that this was going to be a thing, that not only was the overuse a thing, but then Samir Saini from the University of Michigan did this study after the original task force recommendations came out to look at what's happening now for colorectal cancer screening after the task force recommendations. And what you can see here is that there's also a concern for underuse. So in that figure, you see people with the different Charleston comorbidity scores. So people in good health is 0, intermediate health with 1 to 3, and in poor health with greater than 4 comorbidities. And the age range from 50 to 60 and 70 to 75, you see pretty robust screening utilization. However, now you kind of see this huge drop off at 75. So people there, there was concern that people interpreted the task force recommendations of, well, I guess at 75 we stopped screening. And for screening, it's really important to remember if people haven't undergone screening, even if they're in poor health, it may be the right thing for them to do. So this was concerning after the task force recommendations came out, that not only do we have a concern for overuse, but we also have a concern possibly for underuse. So at the time, the summary of the literature was there was significant overuse. Not all the studies used the same definition of overuse, but mostly people were using a binary classification scheme of these people should have been screened or they shouldn't have been screened. It didn't account for uncertainty in clinical decision making, especially in that intermediate group that I talked about for the case number 2, like where it's really hard to know whether they would benefit or not. That patients, we knew from the patient side that they lacked the knowledge and they would just defer and prefer screening at this point. And so we knew that any intervention that we were going to consider, we needed to consider both overuse and underuse as a potential problem. So it was pretty complex to be thinking about a bidirectional effect. So we then did some pilot work, and I'm going to now describe the trial that we performed to try to do just that, which is try to get people who would benefit from screening to undergo screening and people who didn't to not undergo screening. We had several problems, not the least of which was that there was no appropriate outcome for appropriate colorectal cancer screening, which was obviously a huge barrier when you're trying to do a trial, and that the intervention needed to address both overuse and underuse as well. So what we had to do was we developed an outcome metric that accommodated providers' clinical decision making that we had discovered, which means that there was an intermediate group that was more preference sensitive. And we also wanted to test an intervention that we would nudge patients according to the nudge patients for their screening decision in order to maximize the benefit and minimize the harms on an individual level. So here's what we came up with: a measure for appropriate screening that would be the outcome for our trial. It was developed based on literature and it provided more than just a binary outcome. And these categories were determined by age and comorbidity. So as you can see, we use the Charleston comorbidity score. Most people were using it at that time, and it correlates with life expectancy. So 0 is obviously the best health, and greater than 4 is people in poor health, with 1 to 3 in the middle. And our outcome was, for appropriate outcome was for those people in the green, the screen, then that would be the way, the directionality we wanted people to go as far as screening. So for the people in good health, we wanted them to be screened. The people in the lower right, with the red, we did not want them to be screened. And then in the middle group, what we allowed, we were agnostic as to whether they underwent screening or not, but we wanted them to have a discussion with their provider. So this is the preference sensitive group. Hope that makes sense there. Any questions on that? And for those of people, I don't know if it's anybody on this call, but that aren't aware of or not too familiar with patient decision aids, the purpose of these is to facilitate patient choice. And traditionally, the use has been in what we call preference sensitive decisions. So O'Connor was kind of the mother of decision aid development, and what was considered a preference sensitive decision was whether the benefits or harm ratios were very close. And so you didn't know whether a person would benefit or not, or that the outcome was sensitive to the patient's values. Typically, the examples used, the conditions used to promote shared decision making are traditionally PSA testing and mammography. Also, decision aids have been used for colorectal cancer screening, not necessarily in the older group, but for those who were trying to determine what test is the right test for them that they would prefer to undergo. And there have been multiple colorectal cancer screening decision aids focused on testing options. They've been shown to increase patient knowledge. They'd also been shown to promote discussions about colorectal cancer screening options with their providers. And it also most of them had been demonstrated to increase screening participation when the decision aid was used to facilitate the choice. But we were trying to do something different. We wanted to apply a colorectal cancer screening decision aid to an older population where it may not be appropriate to undergo screening. So at this point, decision aids had not been applied to an older population. And our goals were multiple. As I described earlier, we wanted to nudge patients according to their potential benefit. We wanted the tool to facilitate a discussion, especially in people who were perhaps in that preference sensitive area. And we wanted to allow patient preference to be okay, no matter what they decided in that middle group, where it was unclear whether they would benefit or not. So here's a screenshot of their decision aid. This is kind of the broad brush of what we presented. So we talked briefly about screening modalities, but we didn't want to focus the decision making just to be on the screening modality. We really wanted people to understand the risk and benefits surrounding colonoscopy, because even if people had a stool test, they would often have to proceed to colonoscopy if that was positive. So we focused on the potential risk and benefits of screening colonoscopy. Another key part of this was for older folks to understand the competing causes of mortality and where colorectal cancer screening fit into this. And we also thought it was really important, and especially in our pilot work with patients, to understand the uncertainty inherent when you're applying population level information to individuals, that you may not be able to say that you particularly are the person that would benefit or not. So we wanted people to understand that uncertainty around that of applying this. And people intuitively understand that. We wanted to be clear in the decision aid. And also we had a values clarification exercise for those that are familiar with decision aids. And here is our risk and benefit icon array. Those familiar with decision aids know that this is kind of the expectation. So what we showed is that what the benefit from screening would be on the left, and what the potential harms, and we only had 30-day harms at this point, which was what we had. And one of the things that came out of this is to be very clear that there is a potential death, there's a potential possibility of death, even though it was a small risk of death. And follow-up discussions afterwards, people really tuned into that idea, because I think it's not well known that people actually die from colonoscopies, even though it's not common. And here was one of the key parts of the decision aid, which is putting the potential risk of colon cancer death in context with other causes of mortality. So I haven't described this before, but we basically did a targeted decision aid based on gender and age group. So these were targeted depending on what person's age was, and because of their gender, because of the risk of heart disease or stroke varied quite a bit depending on what group they were in. So we had to make sure that we targeted this to the right person when we were handing them out during the trial. But as you can see, that the chance of dying of colon cancer is much less than heart disease or stroke. And we wanted people to understand that as they're aging. And then we wanted them to think about how to balance the risk and benefits by health state. And we did not tailor it. So we didn't give them specific information. If they were in good health, that they're likely to benefit, or if they were in poor health, that they were unlikely to benefit. But we did provide this balance so that they could see that a person in good health, and this is kind of what I would say was the bottom line or the gist. If you're in good health, you're likely to benefit. If you're in poor health, you're unlikely to benefit. And if you're in fair health, it's kind of hard to know. So that was sort of the take-home point of the decision aid. So we conducted a randomized controlled trial. We used that decision aid versus an attention control. And we used the outcome I described earlier, whether one was appropriate decision making, and that occurred after the visit. We asked the patient what they had decided about colorectal cancer screening. And then we followed people for 6 months and determined whether or not they had undergone screening. We performed this at a Duke Practice-Based Research Network at 14 different practices. Patients were eligible if they were 70 to 84. They could not be up to date with colorectal cancer screening. They were scheduled to see their provider within 4 to 6 weeks, I believe. Because we wanted to show different effect by health state, we actually targeted our recruitment and tried to recruit 150 patients into the good, intermediate, and poor health group. Excuse me. So here's our study process. We recruited people by phone. They underwent an eligibility survey. On the day of their clinic visit, they did a baseline survey. They viewed the decision aid. They did a post-intervention survey. I'll talk a little bit about that. Then they had their provider visit, and then they did a post-visit survey. Then we called them 6 months afterwards to find out whether or not they had undergone screening. Our outcomes were traditional decision-making outcomes for the intermediate outcomes, what their knowledge, values, clarifications, and if they reported a discussion with their provider. And then our major outcomes were, did they undergo appropriate screening, and what was their decision making as far as appropriate screening goes. So this is, what we expected to have, where we hoped would happen, that we would increase knowledge, that we would clarify people's values, that we would actually increase discussions with providers, and that that the intervention group would result in appropriate screening decisions and behavior. So here is here's our eligibility screen and our randomized groups. As you can see, we looked through a lot of charts, almost 10,000 charts to identify people that were potentially eligible. That was about 3,300. And then 867 completed the eligibility survey, and we randomized 424 of those. We had 6-month outcomes for 208 and 204 in each group. Participant characteristics were similar, so it looks like the randomization had worked. We had a nice distribution by age. The population was primarily white, which represented pretty much what the practices were like. And not surprisingly, people were on Medicare given the age, and most of them were currently retired. The thing to notice from this is that people were highly literate. So the people who agreed to undergo our study, were probably getting some selection bias for that, and that most people had undergone screening previously. So our first question was, is the decision aid itself working, before we look at decision making? And here were knowledge questions that we used to determine whether people had improved their knowledge. We wanted people to really tune into the fact that there was competing causes of mortality, so that was the first question, and that people needed to live long enough to benefit, so that was the second question. And whether or not cancer grows quickly or not, we wanted people to understand that it's a slow growing cancer. We also wanted people to understand that they would have to undergo a colonoscopy. So that was what the decision was about, really, and that there were complications from colonoscopy. So we had piloted these knowledge questions in previous studies, and this is what we used in this particular study. And thankfully, we found a difference in knowledge score between the intervention group and the control group, with a mean knowledge score of 4 out of 5 for the intervention group versus 2.3 out of 5 for the control group. And then we did a values clarity. We did a values clarity exercise as well. And this is one of the measures that's used for values clarity. We had to modify it for our study, but here are the 3 questions that they responded to. You are clear about which benefits of colon cancer screening matter most to you. So are they clear about the benefits? Are they clear about the risks and side effects? And in thinking about both the benefits and the risk, you are clear about which is more important. And they responded and agreed to strongly agree to strongly disagree fashion. Again, we showed an improvement in values clarity. You can see the difference here, with the lower scores representing greater clarity in this particular measure. So we were happy with that. It looked as if the decision aid was doing what it was supposed to be doing. And then looking at reported discussions with the providers, the decision aid generated more discussions than the control group, with almost 60% reporting that they'd had a discussion about colorectal cancer screening. And I guess, some people may be saying, well, that's not that great, considering that they just watched the decision aid, but you have to remember that these people, many of them were pretty, had multiple comorbidities. And so there was probably a lot on the agenda. So we felt pretty good about this as far as generating discussions, especially when you look at other decision aid trials. And then, did the decision aid result in appropriate decision making and behavior? So what did we find there? Just to remind you, here's the composite measure we were using. So the healthy people, we wanted them to report getting screened. For the unhealthy people, we wanted them to report not to get screened. And for the middle group, what we counted in this composite was whether or not they had a discussion. So what we found for screening behavior, meaning whether or not they got screened, we had 55% in the decision aid group at 6 months report that they had been screened, compared to 45 in the control group. So we saw a difference there, as well as, and then we wanted to know, well, if we're getting people to get screened, are we're nudging them in the right direction? So this is screening by health state. So you can see that the difference in the good health state was, so we were pushing people in the good health state, they were more likely to get screened. You can see in the poor health state that people in both groups pretty much did not get screened. And in their intermediate health state, we promoted discussion. So we were nudging people that appeared to be in the right direction. As far as decision making, and this was asked after they had seen their provider, we also saw an effect, which is a little bit bigger than the screening effect, primarily because we didn't have to wait to see if people underwent the test or not. So limitations, this was performed at the Duke Research practices, so it may not be generalizable. It was in the Southeast. We also only followed people for 6 months, not for longer, so things might have changed a little bit if we, traditionally follow people for a year to see if they were screened or not. And again, our appropriate screening outcome has face validity, but it really has not been formally tested. And again, we might have seen different results if we tailored. So if we told people you're in good health, you should go for screening. You're in bad health, you shouldn't go for screening. But we went with the targeted and the less tailored approach. So our conclusions from the trial is we were able to increase appropriate screening decision-making behavior. We promoted screening for patients in good health and increased discussions for those in that intermediate health group. We actually saw no effect in patients with poor health, but people were not undergoing screening in that group already. So implications for future work, basically clinical decision-making in this older group, when you have to weigh comorbidities and age, is very complex. Perhaps a binary outcome is not enough, especially in decisions around colorectal cancer screening. Perhaps we need to be thinking about an intermediate group where discussions would be appropriate and think of them as preference sensitive. And also there's a need to consider the clinical uncertainty of trying to apply population level data to individual patients. And that wraps up the slide portion, and open it up for questions. If anybody has comments or wants to discuss anything, happy to answer questions or talk further.
Thanks, Carmen. I really appreciate it. It's a really nice example of a program of research. You've clearly led from one step to the next and provided really sound arguments. I wonder if you could discuss, because it looks like most of this has focused on colonoscopy. Do any of the other strategies hold promise for lower burden, lowering harms at older ages? I know that colonoscopy still fits into the equation, but it becomes a little bit more diagnostic at some point, doesn't it? If you have a really positive fit or something like that.
Well, I think what you're asking, Jamie, let me clarify, is do we need to only focus on colonoscopy, or could we focus on more stool-based testing? Mm-hmm. And the reason that we focused on colonoscopy is because if you have a positive test, we didn't want to leave people in this limbo, especially from a clinical point of view, like, oh, great, now we have an 80-year-old poor health with a positive FOBT or stool test. And now what do we do? Because we know they may be higher risk than we thought. And now we're screwed because we have to have a colonoscopy or not. So we didn't want to, at that point, we didn't want to push people into getting a stool-based test and then be in this limbo land and not know what to do. So that's kind of why we pushed it that way. Although there's some talk now about considering, even for surveillance people that are older, about using stool-based tests to further risk stratify.
I have lots more questions, but I don't want to consume everyone's time. So if you have other ones, please chime in or put them in the chat. But I wanted to ask you about the harms equation and how receptive folks were to thinking about harms, because I think we've done a notoriously bad job in cancer control and trying to help people talk about harms or understand that harms of screening even exist. I know we deal with this in the lung cancer screening environment pretty significantly these days, but just wanted to get your thoughts about what the experience was with talking about harms and how you handle that clinically.
Yeah, I think, I think there's two questions. One is from doing the trial and testing the decision aid. And I think from the qualitative work and testing it, was surprising to people that colonoscopy actually had harms, which makes me, from a clinical point of view, say, wow, we're doing an awful job of informed consent, you know? Because these people and many of the people had already undergone colonoscopy, but from a clinical point of view, I think now Laura just heard this on my soapbox recently, but I'm gonna get into, you know, how we have selection bias among people, older people. So we were really wanted to make sure that we had people in the poor health group that were participating. So even now you'll see surveys, people are saying, oh, you know, people still want to get everything. Well, when you look at who those people are, they're usually healthy. And so it's appropriate for them to want to get everything. But what we need to do a better job of is identifying people who are in poor health that can hear about harms and that, you know, are willing to maybe think this isn't for them. So I think there's some selection bias going on. I don't know, Jamie, if you've experienced that with lung cancer screening, but definitely in the colorectal cancer screening literature, it's definitely happening. Like there's this thing that everybody wants everything done, but I'm not sure we're hitting all the population.
So in reference to some of the stuff that you talked about early on, particularly your survey of older adults and their attitudes towards colorectal cancer screening and their expectations, and showing that there was a lot of desire for screening. Do you think, I think that was a 2006 paper. I had to kind of look
It's
close.
a long time ago. Yeah.
Yeah. Do you think that those attitudes would still be prevalent, or do you think that over time people have maybe caught wind of the fact that there's, you know, maybe some harms and drawbacks to screening and aren't quite as excited as they used to be?
Surprisingly, I think it depends on the population. So there's been basically that study was redone in a more diverse sample recently, a couple of years ago, and found similar things. But again, that's what I'm saying is I think those people were primarily healthy. And so that's the reason they responded that way. So I'm not sure we've done a great job of really understanding the preferences of people who are not necessarily as healthy.
Yeah. Thanks.
So yeah, there's a question in the chat. Any race, ethnicity considerations, any differences in referrals from physicians or follow-up with colonoscopy about race and ethnicity among older adults? I wish that we had more data on this, but not as much as we would like. That's a really, really good question, especially since our sample was primarily white. And the other big issue, I think, as y'all saw about literacy, that this was a very literate population. So, you know, again, talking to Laura about this recently about, you know, we're selecting in these decision aid trials for people that are highly literate. And Jamie, I'd like to know your thoughts about that. You probably had more diversity as far as that goes.
Yeah, we've had some diversity in terms of educational background, and we've in many ways tried to develop our decision aids for lung cancer screening, the informed decision tools, you know, with a pretty low literacy level, but it's still really hard, you know, with a new technology like low dose CTs to communicate in a low literacy fashion. And we have that data, and we haven't explored if it varies by that yet, but we'll do that and get back with you on it. But it's a challenge to communicate with folks. But I still go back to the fundamental challenge of two beliefs that I believe are probably way too prominent. More healthcare is always better.
Yeah.
In the United States, that's thankfully not shared by the rest of the world, and that all screening is good screening.
Yeah.
Though we've just done such a poor job of communicating with folks, and this is a responsibility of our ancestors in terms of screening, perspectives on screening, of not raising the harm equation, or let alone trying to engage them in a choice. I mean, frankly, the most communications about cancer screening continue to be, get screened or be shamed, and that's not an inviting framework of which to help people make a choice about screening. And you know you know if a woman were to decide not to have a mammogram, I mean, she'd get more grief for that choice to not have one than lung cancer screening folks are to to get one.
Yeah.
So
Hey, Carmen, Channing,
Yeah.
great talk.
Hey,
Thank you
Chan.
so much.
Thank you.
I'm wondering if you could talk a little bit about what it was like to implement this tool at these practices. Like, did you get pushback from clinic staff? Did you get any feedback from the doctors about, length of time it took to discuss this wonderful decision aid that patients brought into the practice?
That's a really, really good question. And part of what I didn't discuss here is some of our work implementing decision aids while I was at UNC in our practices. So we did not, because this was more of an efficacy trial. And one of the benefits of working through the Duke, those practices with Duke, is they were used to research. So as far as implementing in a real world practice, it probably wasn't, that applicable. Because the physicians are used to participating in a bunch of different studies. We made sure that people got there early, so it wasn't interfering with their clinic time. We actually did a good job of that and didn't have any complaints around that. I think the decision aid took about 10 minutes to go through, but they had to do surveys and all of that stuff as well. So, this was a well-oiled research machine through the Duke PBRN, which would be very different than if we were trying to implement this in the real world, as you know, since we tried to do a colorectal cancer screening decision aid for not old people in our world. So, and I know that one of y'all's, you and Dan's mantras is to make sure that you develop things that are implementable. We had, we did not use an electronic version because of the age range. And we've done a lot of work in previous with decision aids about implementation pre-visit, and trying to get people to look at stuff before they come in, which depends on what it is and how successful it is and how long it's been. But I guess the short answer is this was definitely not an implementation trial, nor, we were trying to push and determine the efficacy, not the effectiveness.
Carmen, you made a comment about, stimulating 60% of the folks to have conversations. I think that's pretty remarkable. I mean, we'd be happy if we reached 15% or 20% in the lung cancer screening context. So that's quite impressive.
I agree. I was just wondering if you got any feedback from the clinicians about like the quality of the conversations that they had based off of the tool.
Yeah, not much. One of the things we knew, because Mike Pignoni's early study in the early 2000s just about colorectal cancer screening in age ranges between 50 and 75 was that you needed to have a visual cue. So we made sure that they had their values clarification piece with them, and that was part of the intervention. So I think that kind of stimulated some discussions. Y'all, and our kind of the funny thing is the attention control was driving safety. So I'm sure that some of these clinicians were talking about driving safety in the control group, and they were like, "What the heck is going on?"
So thanks, Carmen. Great talk.
I did think that was a pretty interesting control group condition, but I didn't want to ask too much about that because I thought it'd be an interesting rabbit hole, but a rabbit hole for cancer screening nonetheless.
No, yeah.
But I want to push back just a little bit, because I'm not a primary care clinician on the implementation issues, and because I think I guess I want to say there's got to be some kind of balance where doing the right thing is worth a few extra minutes or a few points of frustration here. But I admit I'm not a primary care clinician, so you know, I'm welcome to being hit over the head with that. But how can we get our system to accommodate the right thing to do to help people be introduced to this choice? Instead of making us have a briefer and less effective intervention, forcing our system to understand the value of this proposition.
Well, I think there's several things. One of which, you know, the original idea behind decision aids is to increase the patient knowledge before you go into the room. So now Victor Montori might argue another way, which is, you know, you should be doing that while you're flipping cards. But ideally for me as a clinician in primary care, people come in and they have high knowledge and they kind of already thought about the question. They can't say, you know, I have this one question. What do you think? This is what I really want to do. I love that. So, you know, that from a clinician point of view, that makes it great. You know, I can say, this is great. I do think it would be nicer to kind of, you know, and this was not the time to do it. I don't think we were ready. I'll be interested in y'all's thoughts. We did nudge people with the likelihood of benefit. So we didn't push them one way or another, depending on their health state. Because, you know, at the time, being preference sensitive was the way to go. So we thought we were kind of even cutting the margin a little bit by saying, oh, we want to nudge you this way or this way. But I think it would actually help the clinicians if you said that more directly, so then they can follow up with that, you know, given that we still have the uncertainty about whether that individual is going to benefit or not. So I think preparing people ahead of time makes a huge difference from a primary care perspective. So you kind of, and then that they've thought about it beforehand. And then, you know, the age old question that I've been working on since I've been here is, can you document this in the EMR? Can you use the EMR to help you?
Good point. Any final questions, comments? We can actually wrap up close to time. Carmen, thank you so much. I greatly appreciate you. These are really important issues. Obviously, colorectal cancer screening is something very important in our communities, and this is a really interesting question about across the board with regard to older folks and decisions to stop or to sustain screening. So thanks for your leadership in addressing those. And
Sure.
I want to remind folks about Katie Schmidt's talk on Friday. For those of you who know Katie, she is an absolute hoot, and will give a great presentation on some really interesting topics regard to exercise. And then we'll see you in the new year with Dr. Wynn's talk. So thanks for coming. And if you have other ideas for follow-up topics or folks you'd like to see speak, we're working on finalizing the schedule for the spring. And happy holidays, stay safe, and take care.
Thank
Thank you,
you.
Jamie. Thanks, everybody. Yeah. All the best and happy holidays.
Take care, Raj.
Okay, bye.
Thanks, Carmen. Great job.
Of course, Jamie. Thank you, Ellen.
I'll be back in touch with you at the latest after the new year with some stuff. But if Aaron and I come up with some things that we might be able to send for you to look through, we'll do that as soon as we can.
Okay, sounds
Okay.
great. No rush. Just wanted to make sure. Okay,
Okay.
take care.
Gotcha. Bye-bye.